welcome back to the deep dive. Now, if you're a GP trainee, you know the AKT exam. Well, it loves specifics, especially in neurology. It's not just about general knowledge.
Not at all.
Today, we're aiming for a precision strike. We're diving into those tricky decision points, the safety rules you absolutely have to know, and those, classic diagnostic triads that just keep coming up.
That's exactly the plan. Yeah, we're pulling out the essential diagnostic bits, the really clear management steps, focusing right on those moments in clinic where you, as the GP, have to make a call.
Right. Starting meds, working out referral times, getting that DVLA form right.
Precisely. It's all about those clinical decision points that matter for the exam and, of course, for safe practice.
So our blueprint for today. It's very packed, but hopefully really high yield. We're tackling dementias first, how to tell them apart, then movement disorders, getting the management right, acute peripheral neuropathies like GBS. Then the big one, epilepsy and those non-negotiable DVLA rules.
Always a favorite.
And finally, wrapping up with some acute CNS stuff and headache prophylaxis. Okay, let's unpack this. And maybe the best place to start is where many GPs feel the pressure, the whole spectrum of cognitive decline and dementia.
Yeah, definitely. Look, when someone comes in with memory worries, your first job, especially thinking about the AKT, is differentiation. You've got to sort of categorize that cognitive change pretty quickly.
Because the workup and management are so different for each type.
Totally different. The top four, Alzheimer's, vascular, Lewy body, frontotemporal, they all need a distinct approach.
Okay, let's start with the most common one then. Alzheimer's disease, AD.
Uh,
Our sources paint a picture of that slow, gradual memory loss. Forgetting names, getting lost.
That's the classic picture, yeah. Gradual, insidious onset. It's really the memory first disorder. And the key thing for management, for the exam anyways, it's all based on severity.
Measured by the MMSE, a mini mental state exam.
Correct. Using the MMSE score. So if it's mild, let's say the score is over 20, the focus is on boosting acetylcholine because those neurons get hit early. That's where you use donepezil, rivastigmine, or galantamine.
The Dr. G mnemonic, right.
Exactly, Dr. G for the mild stage, enhancing that cholinergic pathway.
So why do we switch drugs when it gets more severe? What's the thinking there?
Good question. It's about the underlying pathology changing, or rather becoming more widespread. Once you hit moderate dementia, so an MMSE between 10 and 20, or definitely severe, which is under 10,
Okay.
the damage involves excessive glutamate activity. You get this excitotoxicity happening. So the treatment shifts to memantine.
And memantine works differently.
Completely different. It's an NMDA receptor antagonist. It basically dampens down that excessive glutamate signaling. So you're moving from cholinergic support to glutamate modulation. Knowing why you switch makes it much easier to remember under pressure.
That makes sense. It's not just memorizing names, it's understanding the process.
Yeah.
Now, a quick but critical point on assessment tools. You mentioned MMSE. What else is okay? And crucially, what's definitely not?
Right. The sources are very specific here. MMSE is fine. The 6-CIT, that's okay too. And the AC3. All standard tools.
But,
And this is a big but for AKT purposes, the sources explicitly say never use the GPCO test in this context. You've got to know which tools are appropriate and which aren't. Part of the toolkit is knowing its limits.
got it. Never GPCOG. Okay, moving on. Vascular dementia. If AD is that smooth slide, vascular is more jerky.
That's a good way to put it. Yeah, the absolute key feature is that stepwise decline. It looks like stairs on a graph, not a slope. Drop, plateau, drop again.
Linked to many strokes or vascular events.
Exactly. Recurrent ischemic events. And here's the clinical pearl. Memory loss often comes last in vascular dementia, unlike AD.
Really? So what comes first?
You're more likely to see issues with executive function first, planning, organizing thoughts, processing speed, sort of frontal lobe signs. So if you have a patient with known cardiovascular risk factors, high blood pressure, maybe some AF, past TIA history, and their cognition suddenly drops, think vascular.
Stepwise decline, cardiovascular risk, memory loss later.
Okay.
Now, the two that often present with more striking behavioral changes. Lewy body dementia, LBD. What's the classic triad we need to spot?
The LBD triad. Non-negotiable for the AKT. You need all three, typically. First, fluctuating cognition or attention. One day they seem almost normal, the next they're really confused. Big swings.
Okay, fluctuation. What else?
Second, vivid, well-formed visual hallucinations. Not just blurry shapes. They might see people, animals, complex scenes, really detailed.
Wow. Okay, and the third part?
Parkinsonism.
Yeah.
So the motor symptoms: resting tremor, muscle rigidity, slowness of movement, bradykinesia. If you see that combination, the fluctuation, hallucinations, and the Parkinsonism, LBD should be right at the top of your list.
Got it. Fluctuating cognition, visual hallucinations, Parkinsonism, and the other big behavioral one, Pick's disease, or frontotemporal dementia, FTD. This one often hits younger people.
Yes, that's a key differentiator. PICS often presents earlier, typically under the age of 65. And again, it's not primarily a memory problem initially. It's about the frontal and temporal lobes failing.
So personality and behavior changes.
Profound changes. Personality shifts, apathy, loss of empathy, and crucially, significant social disinhibition. They might say or do really inappropriate things. The sources even mention inappropriate sexual behavior sometimes, which obviously makes it incredibly difficult for families and for the GP to manage.
Definitely challenging diagnosis.
Uh-huh.
Before we leave dementia, we absolutely have to cover the great mimic, the reversible one. Normal pressure hydrocephalus, NPH.
Yes, the classic AKT scenario, because it's potentially treatable with surgery.
So what's the presentation?
It's that memorable triad: wet, wobbly, and wacky.
Catchy. Break that down.
Okay. Wet refers to urinary incontinence, often quite early on. Wobbly is the gait disturbance classically described as magnetic, like their feet are stuck to the floor, or sometimes an apraxic gait. And wacky refers to the dementia or cognitive decline.
So incontinence, gait problems, dementia, typically in an older patient. Is there often a preceding event?
Good point. Often there is. Look for a history of head injury, a previous subarachnoid hemorrhage, or maybe meningitis, something that could have interfered with CSF absorption. That history plus the triad is a massive red flag for MPH.
And management is often surgical.
Primarily, yes. A ventriculoperitoneal shunt, a VP shunt to drain the excess fluid, is the main treatment, or sometimes serial lumbar punctures to drain fluid. If surgery isn't an option, the sources mention acetazolamide might be tried occasionally, but really, it's about structural correction if possible.
Excellent distinction. Now, we need to contrast these chronic dementias with acute confusion. So, pseudodementia versus delirium.
Right. Pseudodementia is basically cognitive impairment that you see only when someone is severely depressed. Treat the depression effectively, and the dementia often lifts.
Okay, linked to mood. And delirium.
Delirium is very different. It's an acute neurological emergency. The key features are an acute or subacute onset. We're talking hours to days, not months or years. There's a disturbance in attention and awareness, and critically, it fluctuates. They can be lucid 1 minute and confused the next, often worse at night.
Rapid onset fluctuates, attention deficit. Got it. For a GP trainee facing someone with acute confusion, what are the absolute must-rule-out causes of delirium, the AKT essentials?
Yeah, the top ones you have to check for. Think PIN-CAAZ sometimes, but the core ones are definitely UTI. Always check the urine. Constipation sounds simple, but it's a huge trigger in the elderly. Medication issues, new drugs started, dose changed, missed doses, drug interaction, and finally, any underlying infection, chest infection, cellulitis, anything.
So UTI, constipation, meds, infection. Find the cause, treat the cause.
And usually, the delirium resolves. That's the goal. And what's fascinating here is the very clear, stepwise approach the guidelines give for managing agitation if it occurs in delirium. You absolutely must try non-drug methods first.
Like reorientation, reassurance, maybe moving them to a quieter room.
Exactly. Simple stuff often works. De-escalation techniques, managing the environment, involving family if appropriate. Only if those fail, and the agitation is severe or causing risk, do you think about medication?
Okay, and if non-drug methods fail and you've ruled out, started treating the underlying cause, what's the pharmacological ladder?
Right. For acute severe agitation, a short course of lorazepam is often used first, especially if rapid sedation is needed. But if the agitation persists despite treating the cause, then the first-line antipsychotic recommended is haloperidol. And this is crucial at a very low dose. Start with 0.5 milligrams.
0.5 of haloperidol, okay. And if that doesn't work or isn't suitable?
Then the second-line options are typically olanzapine or maybe quetiapine, again, usually at low doses. You need to know that specific starting dose of haloperidol and the sequence for the exam, low and slow.
That level of detail is vital. Right, let's pivot. Movement disorders, big topic. Starting with Parkinson's disease, PD. How do we approach management?
Well, first, diagnosis. Remember that key feature of PD? It typically starts unilaterally. One side is affected first. That helps distinguish it clinically.
As opposed to,
say, drug-induced Parkinsonism. That tends to be more bilateral, often starts more acutely after a drug change, and critically, it doesn't respond well or at all to levodopa.
Because the problem isn't dopamine deficiency in the same way.
Exactly. It's often dopamine receptor blockade by the offending drug, like an antipsychotic. So back to true PD. The management decision really hinges on one main question.
Which is?
How much are the symptoms affecting the patient's quality of life, their QL?
Okay, so if QL is significantly affected, they can't work, struggle with daily tasks.
Then you go straight for the gold standard, the most effective drug, levodopa. Usually given as a combination like cobeneldopa or cocaralopa, which includes a decarboxylase inhibitor to reduce peripheral side effects.
Makes sense. Start with the best if it's really impacting them. And if it's not significantly affecting QOL yet, maybe just a mild tremor.
In that case, the guidelines suggest starting with a dopamine agonist instead, something like ropinirole or pramipexole.
Why do that? Why not just start levodopa anyway?
It's about delaying the long-term motor complications associated with levodopa, things like dyskinesias, those involuntary movements, and the wearing off phenomenon, where the drug effect doesn't last until the next dose. Starting with an agonist can push back the need for levodopa, potentially by a few years.
Okay, so it's a strategic delay. But levodopa is very effective initially. You mentioned wearing off. What happens after, say, a couple of years when patients start getting those motor fluctuations? What do we add then?
Good question. When you get that wearing off or other motor issues, the next step is often to add an adjunct medication to basically make the levodopa work better or last longer. The main one to know is entacapone.
Entacapone. How does that work?
It's a COMT inhibitor. COMT is an enzyme that breaks down levodopa in the body, mostly peripherally. By inhibiting COMT, entacapone ensures more levodopa actually reaches the brain and its effect lasts longer, so it helps smooth out those fluctuations.
Stabilizes the levodopa levels. Got it. The sources also mention amantadine sometimes.
Yes, amantadine can be used, often specifically to help with levodopa-induced dyskinesias, those wiggly movements, but entacapone is more for managing the wearing off itself.
And just quickly looping back for the drug-induced Parkinsonism we mentioned, the one that doesn't respond to levodopa, how do we treat that?
Since levodopa doesn't work, and the issue is often dopamine blockade, you try to rebalance the system using anticholinergic drugs. Things like procyclidine, benztropine, or trihexyphenidyl are the main ones used.
Anticholinergics for drug-induced. Right. Let's broaden out from Parkinson's. We need to be able to spot other types of tremor quickly, beyond the resting tremor of PD.
Absolutely. You categorize tremors by when they happen. So you have the resting tremor, classic Parkinson's, often pill rolling, worse when the limb is relaxed.
Okay, then.
Then there's intention tremor, also called action or kinetic tremor. This gets worse as the patient tries to do something precise, like reach for a target or do the finger-nose test. Think cerebellar problems here. Past pointing is part of this.
Cerebellar for intention tremor. And the third main type.
Postural tremor. This appears when you hold a limb against gravity, like holding your arm stretched out in front of you. The classic example here is essential tremor.
Ah, yes, essential tremor. Very common. What are the key features for the AKT? What makes it stand out?
Couple of things for essential tremor. First, it's often autosomal dominant, so always ask about family history. That's a massive clue. Second, it's usually bilateral, affecting both hands, maybe the head or voice too.
And clinically, does anything make it better or worse?
Yes, two key things. It classically gets a bit better with a small amount of alcohol. And it improves with rest, unlike Parkinson's resting tremor, which is worse at rest.
Better with alcohol, better with rest, family history.
Good.
Got it. Treatment.
First-line treatment is usually propranolol, a beta blocker, or sometimes primidone, which is an anticonvulsant.
Okay, now for some quick-fire tremor associations. Linking the tremor type to an underlying cause.
Right, pattern recognition time. If you see a patient with a new fine tremor and they've recently started a new medication, always think, could this be lithium? Very common side effect.
Lithium tremor. Okay. What if it's tremor plus weight loss, maybe missed periods?
Tremor, weight loss, maybe palpitations, amenorrhea that screams thyrotoxicosis. Check the thyroid function.
Hyperthyroidism makes sense. And the classic picture of an alcoholic patient.
Right. If you have someone with a history of alcohol excess presenting with tremor, confusion, maybe jaundice, or spider naivety, you need to consider hepatic encephalopathy. It's often a coarser, flapping tremor called asterixis. Always look for the bigger picture, the systemic cause.
Great associations. Now, beyond standard PD, we need to be aware of the atypical Parkinsonism syndromes, the ones that often don't respond well to levodopa. Let's start with multiple system atrophy, MSA, also known as Scheidegger syndrome.
MSA is the definition of Parkinsonism plus. So they have the Parkinsonian motor symptoms, the rigidity, the slowness, but the plus is severe early autonomic dysfunction.
Autonomic, like blood pressure, bladder control.
Exactly. We're talking really significant problems early on. Profound postural hypotension causing dizziness or fainting when standing up, urinary incontinence, erectile dysfunction. They might also have cerebellar signs like ataxia. These severe autonomic features are the big red flag setting it apart from typical PD.
Parkinsonism plus prominent autonomic failure equals MSA.
Got it.
Got it. And the other main atypical one, progressive supranuclear palsy, PSP. What's the specific giveaway sign there?
PSP also causes movement problems, particularly issues with balance leading to falls early on, often backwards. But the absolute classic clinical pearl, the thing they love to test, is the specific eye movement abnormality. They cannot look down properly. A vertical gaze palsy, particularly down gaze.
Can't look down. That's very specific.
Yeah.
And not seen in standard PD.
Nope. That vertical gaze palsy is highly characteristic of PSP and helps differentiate it.
Excellent. That really clarifies the movement disorders. Let's shift gears now, peripheral neuropathies and spinal issues. Starting with a real neurological emergency, GPs need to spot. Guillain-Barré syndrome, GBS.
Absolutely critical to recognize GBS early. The classic story is rapidly ascending weakness. Starts in the feet and legs, moves upwards over days or sometimes weeks, often described as a glove and stocking distribution for sensory symptoms like pins and needles too.
And often follows an infection.
Very often, yeah. Usually about 1-3 weeks after an infection, commonly Campylobacter jejuni gastroenteritis, but other viruses too. It's an autoimmune attack on the peripheral nerves, causing demyelination.
Okay, ascending weakness post-infection. In primary care, what are the absolute red flags that mean call an ambulance now?
Number one concern is respiratory failure. Any hint of difficulty breathing, shortness of breath, or difficulty swallowing suggests diaphragm or bulbar involvement. That requires immediate hospital admission for monitoring, especially respiratory function tests like spirometry checking their forced vital capacity, FVC.
Respiratory compromise is top priority. What else?
The other really key clinical sign is loss of reflexes, areflexia. If you test their tendon reflexes and they are absent, particularly in the context of that ascending weakness, that's highly suggestive of GBS and needs urgent assessment.
Ascending weakness, areflexia, potential breathing difficulty. Got it. What investigations confirm it in a hospital? What about a lumbar puncture?
The lumbar puncture typically shows something called albuminocytologic dissociation. Fancy term, but it just means high protein levels in the CSF, but crucially a normal white cell count, or maybe just very slightly raised. Lots of protein, no cells.
High protein, normal cells. What?
The high protein comes from the inflammation around the nerve roots, leaking protein into the CSF. The normal cell count helps rule out infection like meningitis. The definitive diagnostic test, though, is nerve conduction studies. They show the slowed conduction typical of demyelination.
And management in hospital.
It's aimed at stopping the autoimmune attack. Two main options: plasma exchange, plasmapheresis, to remove the harmful antibodies, or IV immunoglobulin, IVIG, which helps modulate the immune system. Both are effective. And of course, supportive care, especially respiratory support if needed, is vital.
Okay. And quickly, the variant, Miller-Fisher.
Ah, yes, Miller-Fisher syndrome. It's a variant of GBS. Instead of ascending weakness, it classically presents with the triad of ophthalmoplegia, eye muscle weakness, ataxia, coordination problems, and areflexia. Sometimes called descending GBS, as it often starts with the cranial nerves, associated with a specific antibody, anti-GQ1B.
Good distinction. Moving to another neuromuscular condition, myasthenia gravis, MG. You mentioned time of day is key here.
Absolutely. MG is caused by antibodies blocking acetylcholine receptors at the neuromuscular junction. This means the signal from nerve to muscle gets weaker with repeated use. So the hallmark symptom is muscle fatigue or weakness that gets noticeably worse towards the end of the day or after exercise and improves with rest.
Fatigability. Worse in the evening. That's the core feature.
That diurnal pattern is really crucial for suspecting MG. Might present as droopy eyelids, ptosis, or double vision diplopia that worsens as the day goes on, or difficulty swallowing or chewing later in the day.
What investigations help confirm it?
You test for the specific acetylcholine receptor, AChR, antibodies. They're present in about 85% of cases. If those are negative, you might check for muscarinic antibodies. The sources often mention single-fiber EMG as being the most sensitive test to show that neuromuscular transmission defect, that fatigue.
Okay, antibodies, EMG, and anything else?
Yes, critically important. You need to do a CT scan of the chest. Why? because MG is strongly associated with thymus gland abnormalities, either hyperplasia or thymoma, a tumor of the thymus. Around 10–15% have a thymoma.
CT chest for thymoma.
Got it. And how is MG managed? What's the GP's role versus specialist care?
The mainstay of long-term treatment is pyridostigmine. It's an acetylcholinesterase inhibitor. Basically stops the breakdown of acetylcholine so more is available at the junction. That helps improve muscle strength.
Pyridostigmine first. What if that's not enough?
If symptoms are controlled, then immunosuppression is usually needed. This is often started by specialists, but GPs might be involved in managing long-term treatment like prednisolone or other agents like azathioprine. And if there's thymoma or sometimes even just significant hyperplasia, thymectomy, surgical removal of the thymus, is often recommended.
Okay. And a myasthenic crisis.
That's an emergency. Severe worsening of weakness, potentially.
For a typical lumbar disc prolapse causing nerve root irritation, the pain is often worse on standing up, walking, coughing, or sneezing, and characteristically gets better when lying down, especially with knees bent. That positional relief is quite suggestive.
Worse standing, better lying down. And the initial management pathway for the AKT.
It's structured and conservative initially. For the first 6 weeks, it's typically watchful waiting combined with advice on staying active, physiotherapy referral, and simple analgesia like NSAIDs, always with PPI cover or paracetamol.
So 6 weeks conservative trial first. What if there's no improvement?
If significant pain or functional limitation persists after 6 weeks, then you'd consider imaging, usually an MRI scan to confirm the prolapse and nerve compression. And at that point, you might also consider neuropathic pain agents like amitriptyline, gabapentin, or pregabalin. Surgery is reserved for persistent severe cases or those with neurological deficits.
Okay, clear pathway. Now for the more complex, anatomically specific spinal cord syndromes. These are high yield because the pattern of weakness and sensory loss tells you where in the cord the damage is. We need that basic anatomy again.
Yeah, quick recap. Remember the main motor pathway, the corticospinal tract, crosses high up in the brainstem, medulla, but the main pain and temperature pathway, the spinothalamic tract, crosses almost immediately upon entering the spinal cord at each level. Proprioception vibration, dorsal columns, ascends ipsilaterally and crosses high up too.
That crossing point is key. Okay, let's do the syndromes. Anterior cord syndrome affects the front part.
Right, often caused by occlusion of the anterior spinal artery. It knocks out the corticospinal tracts and the spinothalamic tracts, so you get motor weakness below the lesion, typically worse in the legs than the arms, LLUL, and loss of pain and temperature sensation below the lesion. But proprioception and vibration, served by the posterior columns, are usually spared.
Weak legs, loss of pain temp, spared vibration position sense. Got it. Central cord syndrome, middle of the cord.
Usually caused by hyperextension injury, especially in older people with pre-existing neck arthritis. It affects the crossing spinothalamic fibers and the central parts of the corticospinal tracts. The classic pattern is weakness that's worse in the upper limbs than the lower limbs, ULLL. Sensory loss can be variable, sometimes a cape-like distribution for pain temp.
Arms worse than legs.
Yeah.
Okay, and the really specific one, Brown-Séquard syndrome. Half the cord is damaged.
Exactly, a hemisection. This perfectly illustrates the anatomy. Because the motor corticospinal tract has already crossed high up, damage to one side of the cord causes ipsilateral, same side, weakness below the lesion. But because the pain temperature spinothalamic tract crosses immediately, the damage knocks out the fibers from the opposite side. So you get contralateral, opposite side, loss of pain, and temperature sensation starting a couple of levels below the lesion.
Ipsilateral weakness, contralateral pain temp loss, plus ipsilateral loss of proprioception vibration, as those tracts haven't crossed yet either.
Precisely. Understanding where the tracks cross makes Brown-Séquard make sense rather than just memorizing it.
Definitely. Now, when assessing any back pain, we always think red flags. But the yellow flags are also important for predicting outcome, right?
Absolutely. Red flags are the serious spinal pathology alerts, cauda equina syndrome symptoms, bilateral leg weakness sciatica, saddle anesthesia, bladder bowel dysfunction, suspected cancer, history of malignancy, unexplained weight loss, night pain, infection, fever, IV drug use, recent infection, or significant trauma fracture. Those need urgent action.
And yellow flags, more psychosocial.
Yes. Yellow flags are factors that predict a higher risk of developing chronic pain and disability. Things like a negative attitude or belief that pain is harmful, fear avoidance behavior, low mood or social withdrawal, Problems at work or seeking compensation benefits, being female, and yes, sometimes repeatedly asking for sick notes can be a flag for underlying issues preventing recovery. Recognizing these helps tailor management beyond just the physical symptoms.
Good point. Finally, for this section, two specific conditions, ALS, amyotrophic lateral sclerosis, and syringomyelia. ALS first. What's the key pathological feature?
ALS, or motor neuron disease, is characterized by the degeneration of both upper motor neurons, UMNs, and lower motor neurons, LMNs. That combination is the hallmark.
So you see signs of both.
Exactly. You'll see UMN signs like hyperreflexia, increased tone, spasticity, a positive Babinski sign, and alongside those, LMN signs like muscle wasting, atrophy, weakness, and fasciculations, muscle twitches. Often starts in one limb or with bulbar symptoms like slurred speech, dysarthria, or swallowing difficulty, dysphagia. It's progressive and sadly fatal.
Grim prognosis. What's the
Yep.
management focus? Is there a cure?
No cure, unfortunately. Management is supportive. The only drug shown to slightly slow progression is Riluzole. It might delay ventilator dependence and increase survival by maybe 2-3 months on average. Otherwise, it's about managing symptoms. Non-invasive ventilation like BiPAP for respiratory muscle weakness, PEG feeding for nutritional support when swallowing fails, physiotherapy, salt input.
Riluzole's the main drug, otherwise supported.
Yeah.
And syringomyelia. That's a cyst in the cord.
Yeah, a syrinx, which is a fluid-filled cavity within the spinal cord, usually in the cervical or thoracic region. It often expands over time.
And the classic presentation.
Because it typically starts centrally and expands outwards, it first damages those crossing spinothalamic fibers for pain and temperature. This classically causes a cape-like distribution of sensory loss of pain and temperature sensation across the shoulders, upper back, and arms, while touch, vibration, and proprioception are initially spared. They might burn themselves without realizing. Later, it can cause weakness and LMN signs in the arms, often associated with Chiari malformations.
Cape-like pain temp loss.
Got it. Now, before we move on, let's quickly anchor something you mentioned earlier about proprioception loss. Tabes dorsalis tertiary syphilis affects the posterior columns, right?
That's correct. It damages the dorsal columns, leading to loss of proprioception and vibration sense, sensory ataxia, unsteady gait, especially with eyes closed, positive Romberg sign, and sometimes joint damage, Charcot joints.
And you mentioned the specific pupil sign. Yes, the Argyll-Robertson pupil. The mnemonic is PAP. Pupillary reflex absent, doesn't constrict to light, but accommodation reflex present. Pupils constrict when focusing on a near object. That's classic for neurosyphilis, specifically Tabes dorsalis. Keep that PAP mnemonic in mind.
PAP, pupil, for Tabes dorsalis. Okay, we'll come back to why that's important later. Let's dive into probably one of the most heavily tested areas for GPs, epilepsy, especially safety, DVLA, pregnancy, starting with pediatric epilepsy types.
Right. Need to link the age, the seizure type, and the EEG buzzword for the AKT. 4 key ones. Under 1-year-old, if they have sudden flexion or extension spasms, think infantile spasms, also called West syndrome. The EEG shows a chaotic pattern called hypsarrhythmia.
Under 1, spasms, hypsarrhythmia is West syndrome. Okay. What if they're a bit older, say over 1, with multiple seizure types and learning disability?
That sounds like Lennox-Gastaut syndrome, usually starts between 1 and 7 years old. Multiple seizure types, atomic, atypical absence, often difficult to treat. The characteristic EEG finding is slow spike and wave discharges, less than 3 Hz.
Lennox-Gastaut. Over 1, multiple seizure types. Slow spike wave. Got it. What about the common, generally outgrown type?
That's benign Rolandic epilepsy, typically affects kids aged 4 to 12. The seizures are often focal, involving the face or arm, maybe drooling, speech arrest, and characteristically happen during sleep or early morning upon waking. EEG shows centrotemporal spikes, usually resolves by adolescence.
Benign Rolandic, 4-12 years, sleep morning seizures, centrotemporal spikes.
Okay.
And the most common fit overall in childhood.
Febrile convulsions, extremely common, occurs between 6 months and 6 years of age, associated with a rapidly rising fever. Usually generalized tonic-clonic, lasts less than 5 minutes typically. Importantly, giving paracetamol to prevent fever doesn't prevent the convulsion itself.
And acute management if it lasts longer.
If a febrile convulsion goes on for more than 5 minutes in the community, the standard protocol is rectal diazepam or bical midazolam. Simple febrile convulsions don't usually require long-term anti-epileptics.
Okay, that covers the main pediatric types. Now, a massive safety issue. Epilepsy in pregnancy. Teratogenicity. Which drug is the worst?
This is absolutely critical knowledge. Sodium valproate is the most teratogenic anti-epileptic drug by a significant margin. It has a high risk, particularly of neural tube defects like spina bifida, but also other congenital malformations and developmental problems. Its use in women of childbearing potential is now heavily restricted under pregnancy prevention programs.
Valproate high risk, especially neural tube defects. Any others to be particularly wary of?
Phenytoin also carries significant risks, classically associated with cleft lip and palate, and a pattern called fetal hydantoin syndrome. Topiramate also has risks, particularly cleft liplet. Carbamazepine carries some risks too, lower than valproate but still significant.
So which ones are considered safer?
The current evidence suggests that lamotrigine and levetiracetam carry the lowest risk of major congenital malformations compared to the older drugs. They are generally preferred if an antiepileptic is needed during pregnancy, though no drug is completely risk-free. Preconception counseling is vital.
Lamotrigine, levetiracetam are the least teratogenic.
Oh.
Okay. This focus on safety leads directly to the DVLA regulations, non-negotiable for GP sign-offs. Let's break down Group 1 rules, cars and motorcycles. Standard established epilepsy first.
Right. For someone with established epilepsy wanting a Group 1 license, the rule is they must be completely free from any type of epileptic attack that includes absences, myoclonic jerks, even isolated auras if they affect consciousness or function for 1 full year. 12 months seizure-free.
1 year completely seizure-free. What if it was their very first seizure? An isolated event?
The rules are slightly different for a first, unprovoked seizure. It depends on the specialist's assessment of recurrence risk. If the risk is deemed low, they need to be seizure-free for 6 months. If there are factors suggesting a higher risk of recurrence, like an abnormal EEG or an underlying brain lesion, then it's 12 months, same as established epilepsy.
6 months if low risk, 12 months if high risk after a first seizure.
Got it.
What about seizures that only happen during sleep? Nocturnal seizures.
This is a specific situation. Generally, any seizure means 1 year off driving. However, there's an exception if the person has had attacks only while asleep for a period of at least 12 months. If they can establish this pattern and have never had an awake seizure, they may be eligible for a license. There's also a rule if the only sleep attacks happened more than 3 years ago, they might also be licensed if no awake seizures since. It's complex, relies on specialist opinion.
Sleep-only pattern needs careful assessment. Okay, now a really important distinction. What if a seizure happens because a doctor advised reducing or stopping medication? A withdrawal seizure.
Yes, this is treated differently. If a seizure occurs during a planned, medically supervised withdrawal of anti-epileptic medication, the license is revoked. Initially, the standard 12-month rule applies. However, the patient can reapply for their license earlier after just 6 months, provided the medication that was withdrawn has been successfully reinstated and they have remained seizure-free for that 6-month period after restarting treatment.
So 6 months seizure-free after restarting meds for a withdrawal seizure. That's crucial. Now, Group 2 licenses? Lorries, buses. Much stricter.
Dramatically stricter, yes. Understandably so, given the public safety implications. To hold a Group 2 license, a person with a history of epilepsy must meet 2 conditions. They must have been free of any epileptic attacks for the last 10 years, and they must not have taken any anti-epileptic medication during those 10 years either.
10 years seizure-free A&E off all medication.
Wow. It's a very high bar. For a single isolated seizure, the rule for Group 2 is 5 years seizure-free and off medication, plus favorable specialist assessment.
Huge difference between Group 1 and Group 2. Really highlights the responsibility there.
Okay, let's wrap up this section with those 3 acute toxic syndromes that often get confused: malignant hyperthermia, neuroleptic malignant syndrome, and serotonin syndrome.
Right, classic exam fodder. Need to know the trigger, the key signs, especially pupils, and the specific antidote for each.
Okay, malignant hyperthermia, MH. First.
Trigger.
Anesthetics, specifically volatile anesthetic gases like halothane, sevoflurane, or the muscle relaxant suxamethonium. It's a rare genital susceptibility.
Signs?
Rapid onset muscle rigidity, extremely high fever, hyperthermia, tachycardia, acidosis, and a massive rise in creatine kinase. CK. Pupils are usually normal.
Antidote.
IV dantrolene. Acts directly on muscle to reduce calcium release.
MH. Anesthetics, rigidity, fever, high CK, normal pupils, RX dantrolene.
Got it.
Next, neuroleptic malignant syndrome, NMS.
Triggers typically antipsychotic medication, especially older typical antipsychotics, but can happen with atypicals, or sometimes abrupt withdrawal of levodopa in Parkinson's patients.
Signs, similar to the MH.
Similar in some ways, rigidity, led by rigidity, high fever, autonomic instability, labile BP, tachycardia, altered mental state. CK is usually elevated, but maybe not as dramatically as MH. Again, pupils typically remain normal. Onset is slower than MH, usually days.
Antidote management.
Stop the offending drug immediately. Supportive care is crucial. Specific treatment can include bromocriptine, a dopamine agonist, or dantrolene if rigidity and fever are severe.
NMS, antipsychotics, levodopa withdrawal, rigidity, fever, autonomic dysfunction, normal pupils, RX stop drug, plus need bromocriptine, dantrolene.
Right. Finally, serotonin syndrome.
Trigger is excess serotonin activity, classically from combining serotonergic drugs like an SSRI plus an MAOI or SSRI plus St. John's wort, or even overdose of an SSRI.
Signs. How is it different?
This one has more neuromuscular excitation. Think hyperreflexia, myoclonus, jerking, tremor, ataxia, sweating, confusion. Fever and rigidity can occur, but may be less prominent than NMS. The key differentiator often quoted is the pupils. In serotonin syndrome, they are typically dilated mydritis.
Dilated pupils, that's the key difference. And management. Again, stop the offending agents immediately. Supportive care. Benzodiazepines for agitation myoclonus. In severe cases, the specific antidote mentioned is cyproheptadine, which is a serotonin antagonist.
Serotonin syndrome, serotonergic drugs, neuromuscular excitation, clonus, hyperreflexia, dilated pupils, RX stop drugs, plus managed cyproheptadine. Perfect summary. Let's move into our final main section, acute CNS events and headache management, starting with stroke and TIA, initial management.
If you suspect an acute stroke or TIA and there are no contraindications, like bleeding, the immediate step is 300 milligram aspirin, loading dose.
300 milligram aspirin straight away. How long for?
Continue the 300 milligram aspirin daily for 2 weeks. After that, you switch to long-term secondary prevention, which is usually clopidogrel 75 milligram daily indefinitely, or sometimes aspirin plus dipyridamole.
Okay, what's the nuance if the patient is already on low-dose aspirin?
Good point. If they're already taking, say, 75 milligram aspirin daily for cardiovascular protection, you do not give the additional 300 milligram loading dose. Just continue their usual low dose and ensure they get urgent specialist assessment.
All right, don't double up. How quickly do they need to be seen by a specialist after a TIA?
It depends on when the symptoms occurred. The urgency is risk stratified, often using the ABCD2 score, age, BP, clinical features, duration, diabetes. But the simple rule for referral timing is, if symptom onset was within the last 7 days, they need to be seen by the specialist stroke service within 24 hours. If onset was more than 7 days ago, they should be seen within 7 days.
7 days equal 24-hour assessment. 7 days equals 7-day assessment. Clear. And DVLA advice after a stroke or TIA.
They must stop driving immediately. The minimum period off driving is 1 month, but that's only if they make a good recovery with no significant residual neurological deficit. If they have ongoing weakness, visual problems, cognitive issues, etc., the period will be longer and requires formal DVLA notification and likely specialist assessment of fitness to drive.
1 month minimum, maybe longer.
Right.
Let's quickly contrast the two main stroke territories based on weakness patterns, MCA versus ACA.
Middle cerebral artery, MCA stroke, is the most common. It affects the lateral side of the brain. Think face and arm weakness predominantly, often worse than the leg, ULLL. May also have speech problems, aphasia if dominant hemisphere, or neglect if non-dominant.
MCA, face, arm, leg, ACA.
Anterior cerebral artery, ACA stroke, affects the front and medial part of the brain. Think leg weakness, worse than arm weakness, LLUL. Personality changes, apathy, or disinhibition can also occur due to frontal lobe involvement. Urinary incontinence sometimes too.
ACA, leg, arm, personality changes, good distinction. Now, acute infections, meningitis, that single dose of benzyl penicillin in primary care before transfer, need to know the doses.
Absolutely critical safety net if meningococcal disease is suspected and transfer is delayed. The IM benzyl penicillin doses depend on age. Under 1-year-old, 300 milligrams. Ages 1 to 9 years. 600 milligrams. Age 10 years and over, including adults. 1,200 milligrams, 1.2 grams.
300, 600, 1,200 based on age. Got it. And prophylaxis for close contacts.
Yes, but only for confirmed or strongly suspected meningococcal meningitis, not for pneumococcal or viral. Close household contacts or kissing contacts usually get prophylaxis, typically with rifampicin, beware interactions, or sometimes a single dose of ciprofloxacin. Needs to be given quickly.
Only for meningococcal contacts. Rifampicin or Cipro. Okay, let's finish with headache management, focusing on prophylaxis for the chronic types seen in primary care. Migraine first.
Migraine prophylaxis options include beta blockers like propranolol or metoprolol. Topiramate is another effective option, and acupuncture is also nicely proved.
Topiramate, though, We mentioned it with pregnancy.
Yes, absolutely crucial reminder. Topiramate is effective for migraine, but is teratogenic, risk of cleft lipolate. It should absolutely not be used in women of childbearing age unless they are on highly effective contraception. The guidance often specifies needing 2 concurrent forms, and they're fully counseled about the risks. Huge safety point for GPs.
2 forms of contraception if using topiramate in women of childbearing age. Got it. Acute migraine treatment.
Simple analgesics or NSAIDs first line. Antiemetics are often needed. If those fail, then triptans are the mainstay, sumatriptan, rizatriptan, etc. Nasal spray or subcutaneous injection sumatriptan can work faster for severe attacks.
Okay. Cluster headaches. The really severe one-sided ones.
Excruciating pain, often described as stabbing or boring around one eye, usually lasts 15 minutes to 3 hours, can happen multiple times a day in clusters. Associated with autonomic features on the same side, tearing, red eye, nasal congestion, eyelid drooping, tosismiosis, Horner syndrome sometimes.
Acute treatment.
2 main things work acutely: 100% high-flow oxygen via a non-rebreather mask, and subcutaneous sumatriptan injection. Oral meds are usually too slow.
Oxygen or injectable sumatriptan for acute cluster headache. Prophylaxis.
First-line prophylaxis is usually the Rapamil, a calcium channel blocker, often needing high doses under specialist supervision. Short courses of prednisolone can sometimes be used to break a cluster.
Verapamil for cluster prophylaxis.
Right.
Tension headache, most common type.
Bilateral, featureless headache, often described as a tight band or pressure. Not usually severe, doesn't typically interfere with daily activities. Management is mainly reassurance. Simple analgesics like paracetamol or NSAIDs for acute episodes.
Prophylaxis.
Often not needed. If frequent low-dose amitriptyline can be tried, or acupuncture is also an option according to Ms. Sarrow. But reassurance is key.
And finally, a quick mention of idiopathic intracranial hypertension.
IIH. Classic phenotype is an overweight young woman. Presents with headache, often worse lying down or bending over, pulsatile tinnitus, and visual disturbances due to papilledema, swollen optic discs seen on fundoscopy. Needs urgent ophthalmology neurology assessment. Management involves weight loss, drugs like acetazolamide to reduce CSF production, sometimes shunting procedures.
Obese young woman, papilledema, headache. Think IIH. Okay.
Right, we've covered a huge amount of ground there, hitting the main management pathways and diagnostic criteria. Now maybe let's just quickly consolidate some of that really core foundational knowledge, the stuff that helps tie it all together for quick recall in the exam.
Good idea. Like those mnemonics that just save time. Cranial nerves, first names, and function.
Yeah, but can't beat the classics. For the names, I to 12. Oh, to touch and feel very good, velvet, such heaven. Olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, hypoglossal.
And whether they're sensory, motor, or both.
Some say money matters, but my brother says big brains matter more. Matching that to the nerves helps you quickly work out function. Basic, but essential.
Definitely. And dermatomes and key reflexes, those come up all the time in neuro exams.
Need to know the main nerve root levels for reflexes and sensation hotspots. The simple ones. C5, C6, think biceps reflex and elbow flexion. C6, also wrist extension, pick up sticks.
C5, C6 biceps.
C7, C8, think triceps reflex and elbow extension. C7, also wrist flexion, finger extension, make them straight.
C7, C8 triceps, lower limb.
L3, L4, think knee jerk, patellar reflex, knee extension via quadriceps, kick the door. L4, also ankle dorsiflexion.
L3, L4 knee, and the ankle.
S1, S2 thinks an ankle jerk, Achilles reflex, ankle plantar flexion, buckle my shoe. Knowing those 4 pairs covers the major limb reflexes tested.
C56 biceps, C78 triceps, L34 knee, S12 ankle. Got it. We also touched on multiple sclerosis, MS, briefly. What are those classic MS-related phenomena that are good diagnostic clues?
3 key ones often mentioned. First, Lermit syndrome, or sign. An electric shock-like sensation that shoots down the spine, sometimes into the limbs, when the patient flexes their neck forward. Highly suggestive of a cervical cord lesion, common in MS.
Lermate's neck flexion causes shock. What else?
Euthos phenomenon, a temporary worsening of MS symptoms, particularly vision problems like optic neuritis blurring or fatigue when body temperature increases, like during exercise, a hot bath, or even just hot weather in summer.
Euthos symptoms worsen with heat. And the eye movement one.
Intranuclear ophthalmoplegia, or INO. This is a specific gaze abnormality caused by a lesion in the medial longitudinal fasciculus, MLF, in the brainstem. When the patient tries to look sideways, the adducting eye, the one moving towards the nose, fails to move fully, while the abducting eye, moving outwards, often shows nystagmus. It's complex but very characteristic of MS, especially if bilateral in a young person.
INO, impaired adduction on lateral gaze. Okay, those three lorimides, Euthophs, INO, big clues for MS-10.
Right, well, that feels like a really intensive run-through of neurology essentials for the AKT. We've really hammered those safety boundaries. The DVLA rules are so crucial, the pregnancy warnings for certain drugs, spotting GBS red flags early, and knowing those clear management steps for things like delirium or Parkinson's.
Absolutely. And hopefully framing it around applying the knowledge helps. It's about recognizing the patterns. Is it the LBD triad? Is it the specific downgaze palsy of PSP? Is it the fatigability of MG? Spotting those key features quickly is what makes the difference, both in the exam and in clinic.
Definitely. So we established earlier that you can get posterior column problems, loss of vibration, and proprioception sense from both subacute combined degeneration of the cord, which is caused by B12 deficiency, and also from tabes dorsalis, which is tertiary syphilis. We know tabes dorsalis has that classic PAP pupil sign, pupillary reflux absent, accommodation present. And B12 deficiency often comes with other clues like macrocytic anemia or a sore tongue. So for your final provocative thought today, when you have a patient in your GP clinic presenting with sensory ataxia, that positive Romberg sign, proprioception loss, how does knowing about the PAP pupil versus the signs of B12 deficiency actually guide your immediate next step? Which single blood test are you going to order first, right there and then, to rule out the most easily treatable and rapidly reversible cause of those posterior column symptoms? Something to think about for your next clinic.